Hello, my name's Dr. Leon Creaney. I'm a consultant in sport and exercise medicine with a particular interest in the management of lower back pain and nerve root pain or sciatica. I'm predominantly based around Manchester in the northwest of England and Cheshire at various locations where I do my private practice. Over the years, I have developed an interest in spinal intervention. This was something that I took an interest when I was still training to be a consultant on the London Sports Medicine rotation. And my first job there was with, as it happened, a neurosurgeon, a back pain surgeon called Peter Hamlin. And I first gained experience and interest there. That really continued throughout my registrar days, as well as doing hands-on practical procedures. If you want to develop an interest in spinal intervention, you will have to go on various courses. There are some good courses in the United Kingdom, but if you really want to get good experience, you're going to have to travel abroad to the Europe courses and also to the North American courses. The best courses that I've been on for spinal intervention were in the United States, where you can really get good hands-on experience with fresh cadavers and fluoroscopy kit. I've also been on very good courses in Germany. Once you have these skills, of course, you need to maintain them by doing procedures on a regular basis, auditing your outcomes and going on refresher courses now and then. So if you do wish to follow in my footsteps, these are some of the organisations and courses that you can look into. This was one that I did only last year with Arthrex, their platelet-rich plasma course, which incorporated spinal interventions, and that was a really good refresher that I've recently been on. So I wanted to talk to you about back pain today. Obviously, very interesting subject, very common, and it's probably the single most common reason for Western people to have time off work. Obviously, there's a very large psychosocial component to the experience of back pain and how well people cope with it and get on with it. Themes include catastrophization and believing that movement will cause harm, and it is important to screen people for these ideas and beliefs to have some understanding of where they're coming from and what they believe about their back pain. It's always important to screen for what we call the red flags as well. Symptoms or signs that may point to a more serious cause of back pain, and the psychosocial factors which we name as the yellow flags, all around a person's coping strategies and beliefs that they have around the back pain. Now, there are some quarters that don't take back pain too seriously, and many people feel that they don't get a good deal when they try to access healthcare resources. Many people are pushed away with an attitude of back pain is self-limiting, don't worry about it, we'll treat it with painkillers, and obviously there's been an epidemic of opiate addiction where people have really inappropriately been put on really quite strong opiates and become addicted to them, when other treatment interventions, especially when applied early on in the course of back pain, should really be utilised instead. Many people that I work with are highly motivated, whether it be sports people or high-flying professionals. They don't want to take this passive attitude to their back pain, as they need to get back to what they're doing, and therefore are often seeking for a quicker solution than self-limiting conditions. Obviously, the causes of back pain are many and varied. Right at the top of this illustration here, we can see probably what's considered the most common cause of back pain, the so-called mechanical or non-specific lower back pain. There is this belief in some circles that the true causes of back pain can't be discovered, and that it's a wasted effort to try. I'm not in that camp. I do try and make an accurate tissue diagnosis and find the structural cause of a person's back pain, as I believe with that understanding you can go on to treat it better. Obviously, other conditions can be diagnosed through a combination of history examination, an appropriate radiological investigation and blood tests, and everything on that page there should be easily diagnosable. We do have to be very careful with our use of imaging, however. We know that asymptomatic findings are very common the older we get, and they can even be very common in young athletes who have a large training load behind them. So in your interpretation of imaging, you have to really understand what could be a normal background finding and what's genuinely pathological. This illustration here shows it really clearly that all of these changes that can be associated with back pain can be normal findings, and their incidence simply rises with age. There are also many findings which are linked to low back pain, which are in some cases relevant and in other cases not. And again, you need to have that experience to discriminate between normal age-related findings and inconsequential findings, and those that may be of pathological significance. So as always with these conditions, we start with a good history and physical examination. We will elicit signs and symptoms and make that provisional clinical diagnosis. Usually I would move on to clarify the clinical picture with some form of imaging. Plain X-ray is really of no significant value in the investigation of back pain. We tend to use MRI, or where it's not available, CT. This can then give us a more refined, combined clinical and radiological diagnosis. However, as I've said before, a lot of these findings can be misleading. A further and useful diagnostic tool is applying treatment and seeing how a patient responds to treatment. This may be conservative management, such as the physical therapies, an exercise program, manual therapy, manipulation, acupuncture, and adjuncts such as TENS and the like. And I would certainly recommend this for all patients with back pain. But for those who fail to progress with conservative management and they may be looking at intervention, response to treatment can be very useful also. When people fail to respond to treatment, we need to ask the question, why? Is it a failure of treatment, or is it an incorrect diagnosis? And at all times we need to review what we believe and question it when things aren't going as we expect. For me, there are several diagnosis groupings that I find useful that will help me determine which treatment I'm likely to lead a patient down. Discogenic pain, which probably accounts for at least half of people with lower back pain, is often quite central in nature and band-like across the lower back, can be typically exacerbated by positions such as leaning forwards or prolonged sitting, and is sometimes relieved by walking. Facet joint pain, which we can see with increasing age, is often paraspinal, so it can be unilateral, can be exacerbated by leaning backwards and rotation, and usually if somebody has genuine facet joint pain, it should respond to a diagnostic block. Nerve root pain should be easy to recognise in most people. They should have positive neural tension signs. and there should normally be a MRI scan with a disc bulge that corresponds to the pain. Sacroiliac joint pain is obviously highly contested. It probably accounts genuinely for about 1 in 6 cases of back pain. I'll go over the Laslett tests in a minute, but genuine inflammatory sacroiliac joint pain, as seen in the inflammatory arthritis group of patients, should definitely not be missed. And obviously inflammatory arthritis, we're always on the lookout for early morning stiffness lasting greater than an hour, nocturnal pain, pain that switches from side to side, or comorbid pathologies such as iritis should raise the alarm in those circumstances. I alluded to the Laslett tests for diagnosis of sacroiliac joint pain. This is quite a good research paper, and this is what most people would use. So the different tests here employed in this paper: distraction, thigh thrust, Gainsland's test on the right, compression of the pelvis and sacroiliac joints, and direct sacral thrust. So these 5 tests become gradually more sensitive the more that there are. Become more specific the more that are positive. So we can see that if somebody has 5 or more positive tests in the final box, this would be 0.88 specificity for sacroiliac joint pain. Although the more tests that are positive, the less sensitive it becomes. So we arbitrarily choose a cutoff point in the middle there, 3. You can see with 3 or more positive Laslett tests, we've got a sensitivity of 94%. So we're going to pick up 94 cases out of 100 of people with genuine sacroiliac joint pain. And with a specificity of 0.78, we're not going to be making a false positive diagnosis in too many cases. So moving on to investigation. Really, in the advanced management and investigation of back pain, these patients who aren't responding to conservative care and need further investigation, the gold standard investigation has to be considered MRI. However, the technique can obviously be used and abused. You really do need to have a good understanding of MRI and be able to read the scans yourselves and not just rely on a radiologist's report, and understand what is normal findings and what is pathological. This was quite a useful study. What they did was they looked at MRI severity and they tried to correlate it against back pain intensity. Various changes seen on an MRI which are associated with back pain, such as the Modic type 1 change, high intensity zones, disc degeneration, disc height loss, and arthritis seen on the facet joints. You can see all of these changes shown in this slide. And what they found, not surprisingly, was that the MRI score did not correlate at all with the experience of back pain. We look for a line of best fit here, and we can see that the MRI score, each dot plotted against initial low back pain intensity, it's essentially just a scatter plot with no correlation between the two things at all. They concluded that MRI correlates poorly with pain, so we can't use it to denote disease severity in people with mechanical lower back pain. So what can we use it for? Well, I'll come on to that later. On a similar trend, how useful is it in the investigation and follow-up of nerve root pain? And they asked the question in this study, do MRI findings at a year predict the presence of pain? They looked at nearly 300 patients. They compared those who had surgery with those who had conservative treatment and took a baseline MRI and 1 at 1 year follow-up. They did a 4-point scale for the nerve root compression based on the MRI findings. And in this group of patients, roughly half went on to have surgery and half had conservative care. But overall, whatever happened to the patients, 84% reported a favourable outcome. So what they looked at next was the size of the disc prolapse compared to the experience of the sciatica. And they could see that at 1 year, even when disc herniation was still visible, which it was in a third of patients, they still had a favourable outcome, and roughly the same numbers in those with an unfavourable outcome. So the presence of a disc prolapse still being there at 1 year didn't seem to predict whether somebody would still be experiencing sciatica pain, and this was in people who both did and didn't have surgery. In fact, people still had visible nerve root compression on the follow-up MRI, but described a favourable outcome. And the numbers were saying similar in terms of nerve root compression seen on MRI in those with and without a good outcome. So even those with disc herniation, 85% reported a favourable outcome. So what they concluded in this study is that baseline MRI cannot predict whether somebody will have a good outcome a year later, whether they have surgery or not. Just continuing with this theme, and I'll get past it soon, this was another study on a similar vein, asking the question, can MRI predict symptoms down the line? And again, the answer was no. And I just wanted to point out, I did allude to this earlier, it's not just age that can cause changes on the MRI. This was a study done in young but elite junior tennis players with a high training load, and multiple lumbar spine abnormalities were found on their MRIs. But these were asymptomatic players. So these were purely coincidental findings. So, what's this slide telling us? This is a study using SPECT-CT, looking at facet joint pain. A SPECT-CT is the combination of a CT scan which gives good anatomical resolution, you can see if a joint is arthritic, and then combines it with a bone scan which gives functional information and essentially measures osteoblast activity and tells you if a joint is hot and active. When you fuse the two images together, you can see if you've got a hot, active joint, which would imply that it's painful. So we can have joints that are SPECT-CT positive or SPECT-CT negative. And what they discovered in this study, if you look at the graph, you can see people with SPECT-CT positive joints were far more likely to have a good improvement in pain relief than those who were SPECT-CT negative. And using this form of imaging was very helpful in comparison to simple clinical examination. We'll come back to this later. So just a little mini summary here on the section on investigation is always be aware that pathology does not necessarily equal pain, and pain doesn't always mean pathology. You've got to constantly question and revise your diagnosis and response to treatment. So moving on now to management. What we do know, obviously, is that most back pain will self-resolve, but it can take a long time, and the longer it goes on for, the more ingrained it becomes, and we do obviously get chronic pain pathways forming in people. So conservative management, the advice always is to stay active. However, I believe that we should intervene earlier to make sure that we tackle those pain generators early on to prevent the pain becoming chronic and for these central and peripheral pain sensitization phenomena to take hold. Some of you may have heard of this group of studies that was produced a couple of years ago. It was done in mechanical lower back pain, where a group from Denmark noticed that people with type 1 modic change and back pain were a subgroup of back pain patients, and when they cultured these discs, they did find a particular bacteria, Propionibacterium acnes, and they postulated that there could be an underlying infective etiology in this subgroup of patients with lower back pain. And they successfully cultured the bacteria. It was a well-conducted study, and as a follow-up to that study, they then went on to treat patients with antibiotics. So here's that second study now. So in the second study, they treated people essentially with 3 months worth of coamoxiclav, known as Augmentin in the UK. Again, very well controlled study, good methodology to it, and in this very carefully selected group of patients with type 1 modic change and back pain, there did seem to be an improvement following antibiotic therapy. Now, this study has been followed up at least once. There was a study published in the BMJ just in 2019, which has refuted the findings of this study. My comeback to that would be that the follow-up study was not a direct comparison, and the methodology was a lot poorer, and in fact I wrote a rebuttal on the rapid responses which was published online. So this remains a possibility for some patients. Now, moving on to the medical treatment of nerve root pain, which is where spinal intervention really can be quite useful. We must never forget that all we're doing with spinal injections is palliating the pain. We're not getting rid of the disc prolapse itself. We're simply waiting for the body to heal itself, and as I showed you earlier, with or without surgery, something like 85% of patients, their nerve root pain will improve spontaneously over the course of 12 months. And here's a really good example of a before and after case. This patient resolved all by themselves, but simply had an epidural injection to tide them over for pain in the meantime. My normal practice is to do a caudal epidural injection for an L5-S1 disc prolapse. You normally get quite good spread of contrast from the caudal epidural space to L5-S1 and often to L4-5 as well. And this is a relatively or very low risk procedure, which is much easier to perform and lower risk than a transforaminal epidural. I only go on to do transforaminal epidural injections if people don't respond to the caudal. Transforaminals are very good. They certainly do outperform caudals and interlaminar, though they do carry a slightly higher risk, particularly of spinal radicular artery occlusion. So you do need to have digital subtraction angiography to perform the procedure. And the other issue with transforaminal epidurals is that you really do need to know exactly which nerve you're targeting, because it's a one nerve procedure. And with many of my patients, for example, who've got an L5 S1 disc prolapse, you look at the MRI and you look at the pattern of pain that the patient has in their limb, and it crosses the dermatomes of both L5 and S1, and clinically you're just not sure which nerve is the main one responsible for the pain. So you've got two options there. One is you can do a caudal epidural because you know it could spread, although somewhat dilutely, to both areas, or you can hedge your bets, choose one nerve and do a transforaminal, or you can do a 2-level transforaminal, which obviously takes twice as long and again involves 2 sets of risk. You have to thoroughly discuss this with the patient, and at the end of the day it's really where they guide you that they want to go. But there is no doubt that transforaminal is the best procedure, and we do have the facilities to do that, and I do them regularly at the Orth Team Centre in Spire, Manchester. The great thing about epidural injections is that they can stop people requiring surgery. So somebody may be heading towards a microdiscectomy, and 1 or 2 epidurals, their pain is under control, their body eventually heals, and they don't need to have it done. And that's a really great outcome, and it's really minimum fuss. It's a day case procedure. Somebody comes in and they go home again within 2 hours. So this is just a little summary here of how efficacious each of those injections are. Transforaminal, we see you get complete pain relief in over half of people, and partial relief, we're now up to 90%, and very few people get no response at all. Caudal epidurals, it's a bit more hit and miss. Up to 60% of people are going to get partial relief, but there is that 40% non-responder rate as well. So that means 40% of patients are going to go on to need a second procedure. It does, to a very great degree, depend on how well your injection spreads when it's administered, and we know that you get better pain relief when it spreads anteriorly or ventrally than if it doesn't. And this is something that we look out for when we do our epidurograms. So as I've said already, my practice for nerve root pain is confirm the diagnosis with clinical information and MRI. I proceed, generally speaking, with a caudal epidural, and if this works, brilliant. If not, I tend to offer a second procedure, which would be a targeted transforaminal. If this is unsuccessful, or if the patient determines that they want it earlier, at this point I refer for surgery. So, in summary, there are various treatments out there for back pain. Their effectiveness is summarised in this table. So coming back to facet joint injections for back pain, I did show you some of this study earlier. This is using SPECT CT to target facet joints and predict the injection of which facet joint will give good pain relief. So I showed you this study earlier. In summary, Group A1, people with facet joint pain who were SPECT CT positive. These people responded best. And we can see that people who are SPECT CT negative don't seem to respond very well at all. So it's a good tool to positively identify target facet joints and also rule out facet joints that you don't want to inject. This is another study saying it's pretty much the same thing. This is what a SPECT CT looks like in the neck. I do also treat necks, although I tend to have necks injected by my radiology colleagues under CT guidance, as it's more accurate and safe. And this is a SPECT CT fusion image in the lumbar spine as well, and you can see bilateral facet joint arthrosis, and both joints are hot. So just a final study on this using SPECT CT to predict which facet joints to inject. Again, nice set of images there indicating hot facet joints. And really what this table is showing us is in this study, SPECT CT wasn't brilliant at having a positive predictive value. So a positive SPECT CT, you were as likely as not as having a response in terms of pain relief, but it does have a really good negative predictive value in terms of telling you which joints you should definitely not be injecting. So we can see a 3 to 17 ratio there in terms of the negative predictive value. And this could be really useful for a number of reasons. One, you're reducing the number of injections that a person needs to have. This could be very useful because I do all of my procedures with patients awake in X-ray for needle phobic patients. And it also allows you to deliver a higher dose of steroid to the correct joints. I'm very quickly, for my doctor colleagues out there, going to run through actual practical techniques. We tend to use a beveled and bent needle to target our spinal injections. This has allowed us to steer the needle better. If we look at a needle here, what we can see is that there is a tendency, because of the balance of forces, for needles to steer away from the bevel. So if I push that needle forwards now, it's going to move downwards. If we then bend the needle, that effect is actually exaggerated. So with the bevel that comes from the manufacturer, it's really quite a small steering effect. But if we enhance the curvature of the needle with an extra kink, we can enhance the steering effect. So the golden rule to remember is that the needle moves away from the bevel or the notch. And when the needle is bent, the effect is exaggerated. So this is just showing you again that principle. It's very important when you're doing injections to obtain the tunnel view. So the angle of the beam of the X-ray needs to exactly align to the angle of the needle, and that's when you can get your accurate needle steer without parallax. If we look at this clock face here, we can see a bevel of a needle in the center of the clock with the bevel at the 12 o'clock position and a perfect tunnel view. If I push that needle forwards now, the needle is going to move towards the 6 o'clock position. So this is our setup picture for doing a transforaminal epidural. Our starting position with the bevel of the needle will be under the chin of the Scotty dog there, that white blob, point P. And then we're going to point the bevel of the needle upwards so that it will steer down somewhat inferiorly. And we might slightly turn the bevel towards 11 or 10 o'clock, and then it will move medially towards the 1 or 2 o'clock position as it advances. So if we were to take a starting position instead there at the red point, we would have to steer the needle superiorly and medially to get it to that point P. So if you do with your needle have a slightly suboptimal starting position but have a tunnel view, you can steer the needle to where you want it to be. It's very important to know which nerve root you're targeting. So remember, for example, that the L5 nerve root comes out from underneath the L5 pedicle, and the S1 nerve root comes out underneath the S1 pedicle. The area that we're looking for is that so-called safe triangle that sits directly under the pedicle. If we go too inferior to that, we're going to actually stick the needle into the spinal nerve, which obviously would make the patient scream. And we need to be aware of our equivalent doses. We tend to use methylprednisolone or triamcinolone. In spinal intervention therapy, there has been a move towards using non-particulate dexamethasone for safety reasons, especially in people who don't have digital subtraction angiography, so you need to know what your equivalent doses are. These are a couple of my own cases. This is an L5 transforaminal, obviously on the right hand side, and you can see the needle in the AP and the lateral view there. This was a facet joint cyst that was impinging upon somebody's cauda equina. This patient had a facet joint injection and aspiration, and the cyst was ruptured, and they had symptom relief, and this was the procedure being done into the facet joint there. This is a slip disc, fairly typical case, a fairly degenerative looking lumbar spine. And there's the end product of our caudal epidural. The black stuff is the contrast, and you can see it spreading particularly around the L5-S1 disc interspace, and you can see that it's actually reached L4-5 and further on this occasion. That's the AP view, and obviously there's the lateral view. You can see the spinal needle in the sacral canal there, and you can see the contrast going up the sacral canal, and then you get that typical Christmas tree appearance as the contrast spreads down the various spinal nerve roots. If you want to, you can push the contrast a little bit further up the canal with a flush. You can see the central picture there, quite concentrated omnipaque contrast solution, and then when you further flush your injection with clear saline and drug, you can see how the contrast dilutes and pushes further up the spinal canal. So that's the end of my presentation today. I hope you enjoyed the past 36 minutes. As I said, my name is Dr. Leon Creaney. I'm a consultant in sports and exercise medicine with an interest in spinal intervention for back pain and sciatica. My private practice is based in Manchester and Cheshire. Thanks.